Nolan of Bay State Physical Therapy is a clinical specialist at the Mass General Sports Physical Therapy Service. Board certified in orthopedic and sports clinical specialties, he holds the certified strength and conditioning specialist designation. Please welcome Dr. David Nolan.
Great. Thank you very much. Thanks everybody for being here today. Appreciate it. I want to thank Bay State and the team from Bay State for the opportunity to speak today, and then for Matthew Soccer as well. The conference they put together looks exceptional, so hopefully we can have a nice start to the day. All right. So a little bit of framework as far as what we're going to think about and look at today. So, soccer injuries are very common, and obviously in one way or another, all of us in the room sort of work with players and trying to keep players healthy and on the field is going to be an important piece. We've got a lot of information in literature as far as, some of the underlying factors that contribute to some of these injuries, and then thinking about how we can ideally try to prevent them. And then certainly in my world, there's a component of that from a rehabilitation standpoint as well. So trying to target specific things that we can look at from an assessment to try to identify people that might be at a higher risk to try to, if we can, prevent injuries before they even happen. And certainly some of them are going to be more serious or significant, or things that are going to limit play. So our objectives for today, we're going to review some of the more common injuries in the soccer athlete. We'll look at assessing the soccer athlete, trying to identify potential risk of injury, and then talk a little bit about developing effective programs to help reduce that risk of injury. So as we go through this, we'll kind of hit some of the more common things, and admittedly this is not an exhaustive list by any stretch, but we'll start with hamstring strains. Hamstring strains are very common, certainly in soccer athletes, but then I would also say in American football we see it a lot as well, and then also in sprinters. So one of the challenges with the hamstrings is any time that it's in its most lengthened position, there's going to be a greater demand there. So in essence, that's when the hip is going to be flexed and the knee is extended. So as anybody is running, that's sort of when their leg is out in that full stride component. So those are pieces that, in field sport athletes, we see a very high incidence of hamstring injuries, especially people that are accelerating and decelerating as well. Soccer specifically, it's probably between 5 and 15% of the injuries that we see, and one of the more common muscle strain injuries that we'll see as well. One of the more concerning or challenging pieces from a prevention standpoint, or in my world from a rehabilitation standpoint, is the recurrence rate is really unacceptably high. Right? And for many people in the room and people that have played or coached for a long time, oftentimes you'll have players, or maybe some of yourselves that I've had a bad hamstring, or I've strained it, or it's something that happens on a regular basis. Certainly my bias to that is I think some of that is related to incomplete rehab and recovery and sort of getting things back. I mean, I know early on, and I played soccer when I was young, and then working with players early on in my career, that we probably worked on getting people back playing just when their symptoms were a bit better, and didn't do as good of a job identifying when they still had some of the factors that likely led to the increased risk that we know is going to be there to sort of set them up for injury. That risk is predominantly increased by combinations of muscle imbalances, and what we mean by muscle imbalances is when you've got muscles that aren't long enough, so limitations in flexibility, and then other muscles that aren't strong enough, so having a balanced sort of position in and around the hip. And our framework for today, what we'll kind of go through is looking at some relatively quick and easy ways that we can assess these things, and the majority of the things that I'm going to show or highlight are intended to mostly be that you can do on the pitch. It doesn't require significant equipment or anything like that, whether that's from a screening standpoint or from things you can incorporate with players from a prevention standpoint. So the hamstrings help flex the knee, but they cross the knee and the hip. So your hamstrings are helping to extend the hip and then also flex the knee. The other primary muscle that's responsible for extending the hip is your gluteus maximus. So one of the bigger muscles in through your glute. So one of the challenges can be that if people are lacking strength in their glutes, often that can increase the demand on the hamstrings. So this bridge exercise, in order to move up into that position, we need the glutes and the hamstrings to be working. Another component that can overload the hamstrings is when the lumbopelvic control or your core control is not as good. So this assessment essentially is looking at can this athlete sort of raise up, maintain that balanced position so you're not seeing the pelvis drop down at all, and then extend the leg out. So when you unweight the leg, maintaining that level pelvis becomes much harder. So it's a relatively quick way to sort of just get a sense of what their strength and stability might be, and alternating side to side. This second video is essentially looking at the same movement, just from a different angle. And then this will sort of move into what we don't want to see, right? And there's lots of things that can go wrong with some of these, but with each of the different assessments, we'll try to talk through some of the more common things that we're generally going to be looking for. The biggest thing with this is when the athlete unweights the leg, is you're going to see that side of the pelvis drop down. So in other words, their inability to keep the pelvis level when they unweight that leg is going to be a sign that there's some underlying proximal weakness. That could be lumbopelvic strength, that can be glutes, that can be hamstrings as well. Another piece that I'll mention as far as just that bridge exercise, when you're just lifting the pelvis up off the ground, if the knees are bent at about 90 degrees, that's going to be a great way to target hamstrings. If you flex the knees in further, it actually makes it harder for the hamstrings to work, and you can probably get a little bit more activation of the glutes, right? One of the things I mentioned before is that the glute max and then your hamstrings are responsible for extending the hip, which is essentially what's happening during this exercise. So by biasing the angle of the knee, how much bend there is in the knee, you can sort of target those muscles a little bit differently. I would say this is a common thing with many of the athletes that we see, is some generally appreciating some weakness up a little bit higher in the kinetic chain that's then going to increase the demand of some of the other muscles. Okay. Again, this would be a good example is even when somebody's hamstring is feeling better, if they have some of this weakness up above, their risk is likely for re-injury is going to remain a little bit high. Okay? So along the same lines, if we think about injury prevention components here, so again, thinking about a similar exercise, now we can have the athlete squeeze a medicine ball or a soccer ball between their knees. All that's doing is sort of engaging some of the other muscles around. You're squeezing, you're getting the adductors to work a little bit, and then as they raise up, they're getting glute max and they're getting hamstrings as well. Another great option for this that I admittedly like a lot is having a band around their knees so that they're pushing out into it to a certain degree. So in the welcome bag, I think you guys should have all gotten a loop band, which is a good example of that. That's helping to get in some of the hip abductor muscles the glute need as well. I look at some of these as a more bang for your buck activity, that by doing the bridge, you're getting some hamstrings, you're getting some glute max. And then if you're squeezing a ball, you're getting adductors. And if you've got a band that's around the athlete's knees, it's trying to pull them in, but they're cued to sort of maintain that tension on the band, you're now getting some of the abductors as well. As we talk about some of the knee injuries and pathologies, that's another sort of key area to sort of cue in on. Okay. Other ways that we can advance some of these things. So, one of the take-homes that you'll see in a few different areas that I talk about is if we introduce an unstable surface, that's often going to make things a little bit more challenging, right? So as you're making the surface less stable by having foam or having something like this, like a Bosu ball, it just adds a little bit of another degree of difficulty. So you can really think about almost any activity or any exercise, one way to progress it, in addition to doing more repetitions or adding resistance, can just be having them do it on a less stable surface. Okay. Again, doing a single leg bridge, even if you were just doing this on the ground or on the field, is going to increase the demand because it's one leg versus two. Now, if you have that plant leg that's actually on an unstable surface, it makes things work a little bit harder as well. Again, with each of these, I sort of can't highlight enough how important the overall form is. Again, if you're seeing your athletes do this, and that pelvis is dropping down, it's probably too challenging of an exercise for them, right? We want to make sure they're doing the right exercises the right way. I can't tell you how often I see people that are doing a battery of things that may be great exercises to target specific muscles, but if they're not doing them correctly, or if they don't have the strength to do them at the level that they're being asked, then you're not necessarily going to get that benefit from it. As we think about the frontal plane or side to side, that's another important piece. And a lot of these exercises are going to sort of, tie into many of the pathologies and the injuries that we might see. So a side plank, so the athlete is just sort of in this sideline position and then raising the pelvis up. So this is now working on some of the proximal musculature, the gluteus medius is a big component of that. Admittedly, this is a challenging exercise, right? So for many people, a regression of this would just be laying on their side and lifting the leg up to the side, right? As that gets too easy, you can make it harder by having them in this plank position, okay? Obviously, with any sort of exercise that's a hold, the longer that they have to hold it, the harder that's going to be, right? So that might start 15 or 20 seconds, and then as people build endurance, you can extend that time a little bit further. Another way to even make this harder is now you can maintain that plank position and now lift the top leg up as well. So again, sort of giving some ideas as baselines here, but thinking about ways you can challenge your folks that are doing really well, or also being able to regress it. I think that some of the tricky part of things is that if everybody's doing the exact same thing, that may be too easy for some and maybe too challenging for others. So paying attention as far as what their form is going to be. Okay. All right. If we switch gears and move down to the knee, knee injuries and ACL injuries in particular are very common. ACL injury is one of the most common knee injuries that we see in sports across the board. And probably the most challenging component is that we know that this is far more problematic in our female athletes compared to our male athletes. There's a number of factors that contribute to that, which is a little bit outside of our scope today, but our female athletes are definitely at a higher risk, which is why a lot of the core stabilization and the proximal strength becomes so important. What is well established in the literature is that we know that we can sort of prevent these injuries. Not 100% of them by any stretch, but we can certainly control a lot of them, right? Maybe spoiler alert as far as the topic today, like yes, we can reduce the risk. So that's kind of what our focus is here. Programs like FIFA 11, FIFA 11 Plus, have shown that you can really reduce the risk of knee injuries across the board, ACL injuries being part of that. Some of that is because we see a very predictable pattern with specific sports, and then with gender as well, when we think about male versus female, sex. So how can we help? Again, part of it is going to come from our assessment. So can we appreciate some of the challenges here? So again, it's going to be typical patterns as far as muscle weakness, and then their dynamic balance and things like that. So different ways that we can sort of assess these things to make sure that we're targeting, improving the strength where we know that they're going to have problems. So a couple of ways that we can look at this. So just a single leg squat test. So the athlete is just standing on one foot, and then they're asked to just squat down. Now, what we're looking for here is for them to do this with a good quality of movement, right? So the things that we're looking at specifically, anything single leg, we want to look at the pelvis and can they keep the pelvis level. What you'll often see is the leg that's unweighted, that side of the pelvis is going to want to drop down, which is telling you that the weight-bearing side is weak, okay? The other component besides the pelvis dropping down is going to be looking at the position of the knee. Ideally with this, we should be able to have our athlete do a single leg squat with the hip, knee, and ankle staying in good alignment. So we want to watch to see, especially what the knee is doing, right? And I'll give an example of that here with what we don't want to see. So you can see here that knee is sort of dropping in. It's what we call knee valgus, or that sort of collapsing in. So that is telling us that there's limited control up at the hip and pelvis, right? So again, a lot of this comes back to proximal weakness, thinking about glute strength and lumbopelvic stability as well, and then just looking from behind. Again, so I would say the two key areas when we're looking at things in single leg, any kind of squat or things like that, is looking at the pelvis. Is the unweighted side dropping down? Ideally, we want them to be able to do that movement, keeping the pelvis level. The other component is you look at the alignment of the leg itself, is making sure that the knee is not sort of collapsing in or falling in. That's going to be indicative of, we want to look closer at where that weakness might be coming from. Okay. When we think about prevention and things like that, again, there's going to be some similarities here with some of what we've already talked about. But a focus is always going to be on the lumbopelvic strength. So thinking about abdominal strength, thinking about glute strength, etc. Again, one of the big principles is that we need proximal stability for distal mobility, right? So if I use an example of overhead athletes, in order to be effective as a thrower, you need good strength in through the shoulder complex, right? If that's not there, we see greater amounts of elbow injuries in our throwers. With our field athletes, if you don't have proximal stability in through the lumbopelvic and glute region, more demand is placed on the distal structures, i.e. knee, and then we'll talk about foot, ankle, and ankle sprains in a few minutes. So some of these exercises are really just designed to try to work on that lumbopelvic and core control. So a plank exercise, and again, the leg lifts is admittedly an added degree of difficulty, so this may start just in a plank position, right? So just in that front plank position, we want to make sure that they're making themselves like a table. You can see that our athlete is nice and straight. You're not seeing their low back bowing down. And you're not seeing when they lift up the leg, similar to the bridge exercise that we talked about. As soon as you unweight the leg, it's often going to be common if they're weak that side of the pelvis is going to drop down, right? So we want to think about them staying nice and level from top to bottom, and then left to right as well, so that the pelvis isn't sort of tipping or twisting at all, okay? Again, if they're able to do a front plank and hold that good position without any of that, you can sort of now think about increasing the degree of difficulty by having them lift the legs up as well, okay? Walking lunges, again, another relatively basic exercise that people can do. You don't need any equipment for it, and certainly can take up the space, like we said, doing some of these things on the pitch. Part of this is really geared towards trying to work on quad and hamstring and glute strength as well. Some again, important things is making sure that our athletes are doing things correctly, right? So as they're coming across, we'll sort of let this cycle through and see the preferred form first. You'll see that the trunk is staying upright, coming down, and you're not seeing the knee come too far forward over the toes. Some of the more common compensations is you'll see that some athletes will have a difficult time sort of keeping their chest and their trunk upright, and they'll cheat by sort of coming forward, or you'll see them have a harder time controlling the knee position, right? So some of the same things we talked about before is not sort of seeing them cheat up at the trunk, or not seeing that knee sort of collapse in either. This can be modified just by how deep they're going, right? So again, the further that they sort of squat down during the lunge, the harder it's going to be. Right? So if they're having a difficult time controlling their form, we can just have them not go as deep or not lunge out as far. Right? So again, helping people understand this isn't just like, okay, go do these things for X number of minutes, but making sure that they're getting the benefit from doing it correctly. And there may be some variability on how one athlete is doing it versus another to make sure that you're appropriately challenging each person. A single leg squat on a soft surface, again, you can sort of just work on this on level surface for sure, but as I mentioned earlier, anytime we add an unstable surface, we're just increasing the degree of difficulty. Now you're incorporating a component of balance. It's a less predictable environment that's going to be happening, so you're getting some co-contraction of other muscles. So again, there's great benefit to doing this just sort of being on level ground. Similar to when we looked at this as part of an assessment, right? The same things are what we want to make sure that we're seeing from our athlete. That as she's coming down, that her pelvis is staying level, that you're not seeing the pelvis drop on one side. And then if you look at the orientation or the alignment of the leg, that hip, knee, and ankle are staying in relatively straight alignment, that you're not seeing the knee collapse in, okay? If that's the case, then that's often telling us that they've got more weakness in through the glutes. They might still be able to do this, but maybe not as deep, right? The deeper that they go into this movement, the more challenging that it's going to be. Switching gears a little bit and talking about ankle sprains now. Again, another very common injury. One of the more common injuries in sports, and I would say admittedly many the majority of people probably don't need, or at least don't seek medical care after an ankle sprain. And certainly I wouldn't suggest that everybody needs to seek medical care. I would think that even with the most severe injuries, most of our athletes, we probably don't need imaging either, unless there's a significant concern as far as fracture. A little bit unrelated to sort of this specifically, but some of that is if they have an inability to bear weight, or if they have significant tenderness to palpation on the bony structures, that elevates our concern about having a radiograph to rule out a fracture. But the vast majority of people that have an ankle sprain, it's truly a soft tissue injury, and many of those folks don't necessarily need to have imaging. Okay? The higher percentage of people that will have an ankle sprain are younger athletes and our young adults, or adolescents, which are admittedly probably the folks that are most active. And lateral ankle sprains, in other words, on the outside of the ankle, are far more common than the inside. Part of that is just the structure. It's a bit of a design flaw that we have, that the medial ankle ligaments, the ones on the inside, are much bulkier and much more robust than the lateral. So that's one component. And then just the mechanism typically as well. Okay. I mentioned this with hamstrings. I'll say with ankle sprains as well that this is another area that we see very often people have a high incidence of re-injury. And I think there's a number of factors to that. Certainly my own bias is I think that sometimes that can be an incomplete rehab. In other words, that somebody has an ankle sprain, they take some time off, the swelling gets better, their pain gets better, but the underlying impairments, in other words, limitations in strength, mobility, et cetera, are still there, but now they're getting back to challenging activity like play, right? That's, in my view, I think that's part of it, okay? The other component is with ligamentous structures, which are different than muscles. You don't have the elastic properties that muscles do. So when you have that tension, or you start to have strains and things like that, or sprains of those ligaments, is that you actually start to stretch them out to a certain degree. They don't maintain their same structure. So once you have an ankle sprain, the likelihood of you having another one starts to come up pretty significantly. Okay. One of the biggest underlying causes of many of the lower extremity injuries that we see, and even some that we're not talking about today, is going to be limitations in ankle dorsiflexion. Ankle dorsiflexion is when, if you try to pull your toes up towards you, so basically bending your foot and ankle up, that's dorsiflexion. Plantar flexion is when you're pointing down. So when we're lacking ankle dorsiflexion, it makes it much harder for us to have our normal gait pattern, which is going to impact running mechanics as well. Okay, so I can't highlight that enough. That I would say that making sure people have adequate mobility at the foot and ankle region, that they've got good ankle dorsiflexion, is a critical thing, not just for ankle sprains, but for other sort of problems as well. Our bodies are generally lazy, but they're smart. They're going to find a way to get things done, right? So, if you're lacking motion someplace where it's supposed to happen, our bodies are going to find a way to sort of cheat and find it from someplace else, right? And I can tell you that the biggest thing that makes athletes patients is when that sort of compensatory mechanism now overloads some other tissue, okay? Ways that we can look at this, there's a number of them, right? But just looking at this ankle mobility lunge test, so again, as she's moving forward, again, the tibia is coming over the foot, which is the same as pulling the foot up towards you. So that's looking at ankle dorsiflexion, right? So we should have, in this position, at least 15 or 20 degrees of ankle dorsiflexion. So what can limit this, I would say very common, is going to be calf tightness. So if the calf has limited flexibility, that's your gastrocnemius and your soleus, that's going to limit the ability to have normal dorsiflexion. You can also have stiffness in the joint itself. Either of those things that limit your ability to have dorsiflexion. Again, when we need that, when we're walking or running, is as our body is coming over our foot and the tibia is coming forward, that's when we need dorsiflexion. So if you don't have that, your body is generally going to try to do something else somewhere to make up for it in order for you to sort of still move forward. Okay, so that's, I would say, a critical piece is sort of looking at general mobility and flexibility as well is going to be one of the bigger roles here. Similarly, as far as the control with this is as the athlete's coming forward with this lunge test, that the knee is coming straight over the toes. versus having the knee drop in towards midline. Okay. So how can we help prevent some of these? Again, looking at underlying strength components, looking at that ankle dorsiflexion range of motion, thinking about their general balance are all things that can contribute to the injury. So assessing those things and seeing if there's pieces that we can try to target in hopes of trying to prevent it. Okay. So again, we've looked at single leg stance, we've looked at balance and things like that. Again, a few things to kind of target here from a prevention piece is, again, looking at the things that we've talked about with anything single leg already. Can they maintain a level pelvis? Are you seeing the hip, knee, and ankle stay in line, or are they sort of collapsing in? Other things that you might see is lots of compensatory movement. So if my balance is challenged and you're asking me to stand on one foot, you might start to see lots of trunk movement, or you might start to see them twisting around or having to put one foot down, right? So some of those different strategies that are telling you that they have some challenges there, right? So, often that's going to be a component that we need to target, sort of other components of strengthening as well. We can make this more challenging by going from standing on a stable surface to standing on an unstable surface. You can make this more challenging by allowing them to have their eyes open, having them close their eyes, right? So lots of ways that we can make things harder as things start to get easier. You can have them go from 20 or 30 second holds into 30 or 60 second holds as well, okay? Single leg squat, and again, this is pictured here with coming down to a chair, but we've shown some other examples as far as just a single leg squat without necessarily needing anything to come down to. Again, this is doing a few things. This is working on strength. It's working on single leg balance because they're just on one foot. And if you watch her ankle as she's squatting down, she's also coming into that dorsiflexed ankle position. So we're working on some of the mobility there as well. Again, another example of sort of more bang for your buck, so to speak, that you're kind of targeting a number of different areas simultaneously. Again, looking at symmetry side to side is important as well. I can tell you anecdotally, one of the things that I see a lot is that people that have had a history of injury, not even just foot and ankle injury, if they've had an injury on their right side, looking at things like this is often doesn't look as good on the right than it might on the left, right? So, even though the injury or the concern might be for an ankle sprain, or maybe they've had an ankle sprain in the past, oftentimes we're going to see some of those other components that we've already talked about that may cue us into lumbopelvic strength or glute strength and things like that. Okay. All right. Other ways that we can think about progressing this a little bit. So again, single leg standing, and now just taking a soccer ball and passing it front to back around, having the athlete do that, which doesn't seem terribly challenging. What that is it's an internal perturbation. An external perturbation is one of the things I enjoy most about being a physical therapist. That's when we get to throw things at people or push them in different directions, right? If my guidance counselor ever told me that you can find a job where you can actually throw stuff at people, knock them around, not get in trouble, still get paid, I think we would have a huge influx in physical therapists in the community. Now, an internal perturbation is when the athlete is doing something challenging, right? So that could be passing a ball, that could be reaching in different directions, things like that. So lots of options here. If you are doing this within a team, you can sort of have athletes sort of even passing balls back to one another, things like that. But just doing something here is now they're having to move their bodies. So now they're no longer just focusing on standing there, sort of with laser focus on something out in front of them to try to maintain their balance. So even though it seems subtle, it increases the degree of difficulty just a little bit. Okay. Other components now, especially when you're thinking about having members of a team doing this, sort of just working on standing on one foot and then just very basically just passing back and forth, right? Again, while you're maintaining that single leg balance, right? So you can focus on specific legs. Again, for younger athletes, you may get an additional benefit of this, that it's forcing them to use what may not be their dominant foot, and you're sort of working on their balance as well. Certainly we all know that people sort of develop or have this sort of dominant leg component, which is generally where they're going to feel more stable. So finding other ways to try to incorporate this as well. And obviously you can make this a little bit more challenging. Easier is going to be making sure that the ball is coming straight back and forth. And now you can not sort of that they have to sort of run in one direction, but moving that ball past to the side a little bit so that now as they have to reach, that's another internal perturbation. So as the ball is coming and it's not coming directly to them, if they have to move one leg out to the side a little bit to trap the ball before they sort of pass it back, that's now challenging their balance a little bit more. Okay. And then making that a little bit more challenging again is now you can have one person sort of tossing the ball and then the other is maintaining that single leg balance, but now just sort of working on kicking back as well. Okay. And again, this allows you an opportunity to work on sort of what may not be the athlete's dominant leg as well. Okay. Other things as far as prevention, again, we've talked a lot about throughout this so far as how important strength is. I think that calf strength, plantar flexor strength is often underappreciated. I talked a little bit about the importance of flexibility, which is an important piece as far as having that dorsiflexion, but being able to sort of come up on the toes, so raising the heels up to work the calf is going to be important as well. So looking at a single leg heel raise, again, we may start people with a double leg heel raise, right? So here, you can have fingertips or hands against a stable surface, so that could be a wall, that could be a goalpost, that could be just about anything. And that's really more just to help to maintain their balance, right? So again, obviously if they're doing well with this, that may not be necessary for a lot of them. But ideally, we want them working through the full arc of motion. In other words, if you've got somebody and they're just coming, an inch and a half off the ground, that's probably not what we want. We want them to get through that full arc of motion, contracting all the way through and then coming all the way back down. We want that strength to be through the full range of motion. Okay. Again, starting with double leg, you can work to single leg, and then sort of increasing the repetitions as well. And I talked a little bit already about the importance of ankle dorsiflexion. I would say for many of our athletes, that's going to be a component of limitations with flexibility in the calf. So working on stretching the calf, I think, is important. A number of ways to sort of look at this or do this. One preferred way, so if we're looking at stretching the calf, this would be the leg that's behind is what's being challenged. Now, the muscles in your calf, there's the gastrocnemius, which crosses your knee and your ankle, right? So, and then your soleus muscle is deeper to the gastroc. It does not cross the knee. And the gastroc and soleus come together to form the Achilles tendon attaching to the heel of the calcaneus. So you'll often see people focusing on a stretch like this with the knee straight. The knee straight is going to help target the gastrocnemius because it crosses the knee. And then with the knee bent. Now, once you bend the knee, you're putting the gastroc on slack, so you're really focusing on the soleus. So benefit of doing that in both positions, I would say that the gastroc is probably where we see the biggest amount of limitation, partly because it's crossing multiple joints. Now, another piece that's a little bit higher level that I think is important is making sure that they're doing this well. And I would say that one of the more common compensations that we'll see when people are lacking dorsiflexion is to turn their foot out and to collapse or overpronate through the midfoot. That's a common compensation that people will have when they're walking or running if they're lacking the normal ankle dorsiflexion that they should have. So in my view, that's an important thing to look for when people are stretching. So in other words, if your athlete is stretching and that back foot is turned out and they're just sort of collapsing through the arch, you're probably not getting the benefit that you want at the gastroc, right? So I'll make sure that I'm cueing them to try to keep the foot turned in or try to maintain a bit of that arch. Again, most folks, their bodies have figured out already if they're lacking motion someplace, well, I can cheat and get it from someplace else. And that's part of what sets us up for some of the different injuries or things that we might see. So again, sometimes it's the education or the attention to detail and make sure people are doing the right things the right way. But in that same position, you can go from the knee straight and then transition into the bent knee to try to target soleus as well. Okay. Other prevention exercises, again, you've seen this, consistently as far as thinking about some of these single leg exercises and having that step down. Again, this can be done on level ground. Certainly, as we've talked about, adding any sort of unstable surface is going to make it a little bit more challenging. And the key things to look for is their form, their dynamic control, right? So it's not just, okay, go do 10 or 15 of these as part of our warm-up, but making sure that they're being done correctly, okay? Again, we want to really, anytime our athletes are doing something in weight bearing, in single leg, we want to be focused on that level pelvis, that you're not seeing one side drop down. If you do, almost always that's going to be indicative of glute strength, and we want to make sure that we're then targeting that, okay? And then if you're seeing that knee collapse in as well, some of that component can also be from the weakness up above. So I would say that, some of our focus with each of these injuries has been specific to the region they're happening in, right? So we talked about hamstrings and looking at the pelvis, looking at the hamstring muscle itself, but also looking at the entire kinetic chain, right? With ankle sprains, we're talking about looking up at what the hip and the pelvis are doing, right? In my view, some of the things that I spend the most time with talking to athletes and coaches and parents and things like that is thinking about what's happening throughout the entire kinetic chain to really make sure that we're not just focused on, oh, you hurt your ankle or you hurt your knee, but we're thinking both above and below that joint, right? I would tell you that the vast majority of people that show up in clinic that have knee pain, right, just they started developing knee pain, almost always we're including specific interventions for the hip and pelvis as well as the foot and ankle, right? So all these things need to be working simultaneously, and I think that that's another big piece, again, and probably a failure of within my profession a lot, is that if we only focus on the location of the injury, we're probably missing the opportunity to fully prepare people getting back to the high level of activity. Again, another sort of helpful component that you can certainly add the degree of difficulty of an unstable surface, but doing this on level ground will be challenging as well. Okay, all right. And to sort of wrap things up, the one sort of non-musculoskeletal piece that we'll touch on is going to be concussions. And again, this will be, brief in a lot of ways, but important to sort of think about as well. We could spend an entire weekend talking about any of these individual injuries, certainly concussion being a big part of that. Some of the bigger concerns are things that we see. Specific to soccer in youth athletes, a lot of this is player-to-player contact, right? So we know that in our youngest athletes, there's actually limitations with rules and things like that as far as when headers start and that sort of thing. But a lot of this can just be people colliding into one another. So that's an important piece. The other component, when you do have folks that are incorporating headers into practicing games, a lot of it is the volume, right? So there doesn't have to be a really singular significant event. This can also be sort of smaller bouts of challenges over a period of time as well. There's a high number of people that will report having a concussion. I mean, I remember, things have changed a lot for the better, but certainly probably not where they need to be, right? Any given weekend in different sports, we can all see highlight reels about somebody who got hurt. We've seen a lot in American football this season that, clearly had an event and then, were allowed to get back into play, right? And I think that's where the standpoint of, when in doubt, sit them out comes from. So making sure that we're not elevating the risk by minimizing what could be a significant injury and allowing people to get back into play. This is a relatively high incidence in soccer players for sure. And we know that our female athletes often will have a more prolonged recovery. There's a lot of contributing factors that many of them not fully understood. But our younger players and then certainly our female athletes are probably at a higher risk for more prolonged symptoms. Now, one of the, and obviously we can't prevent player-to-player contact, and obviously at higher levels, using your head is a very important part of the game. But a big component that elevates the risk is not having the neck strength to be able to tolerate those things. So in a very simplistic way, if two players are going up for a ball, not even if they necessarily hit heads, but if they bang into each other, and then you get a bit of a whiplash moment at the head and neck, right? So your brain is sort of sitting inside of there, and it essentially is now sort of crashing into the sides, into the skull. So there's a component there that even injuries that don't look terrible from the sideline or when watching at home from TV can be challenging from the structures that are there. I think that's the other challenge with concussions is that it's often you see horrendous plays sometimes, and then some people are fine. and then you see what seems to be a less significant injury, and they can have really challenging or prolonged symptoms. So you can't make decisions based on sort of how it looked as an observer, but making sure that we're assessing the athlete. Now, the other piece that I think is important as well is understanding that, one, concussions are a significant injury and a significant problem in their own right, but related to everything that we've already talked about, the incidence of musculoskeletal injury after concussion is through the roof. In other words, even if you have an athlete who's had a concussion, has a recovery, and does well and gets back to play, that athlete's risk for an ACL injury, for a hamstring injury, for an ankle injury, any of those things is much higher than it was before. Okay? That's something that we've seen more now as far as the return to play, and what we're thinking about with giving clearance is that, keeping in mind that many of those athletes, especially if we're talking about our female athletes, their risk for an ACL injury may have been very high to begin with. And now if they've had a concussion, we're only increasing that even further. Okay? So in my view, that is a component from a rehab or a management or a medical management component, is making sure that are they cleared to get back, not just from the concussion side of things, but making sure that the MSK side of things is also in a good place, that we're not sort of dealing with this elevated risk and setting them up for an additional injury. Okay. So again, a big component as far as, what can we do, and certainly in other sports, there's, in soccer, there's been adjustments to rules over the years in an attempt to try to decrease this. In American football, we've seen changes in rules, but then also in helmet design and things like this. So, our goal is to try to reduce, we're not going to eliminate the concussions from happening, but the better that we can sort of control it. So I would say the things that we can do is really trying to focus on the vestibular components, which is going to be balance, and then also the strength components, right? And again, I think our younger athletes, especially our females, that's part of what is driving the risk up higher, just because of the strength and the development sort of is often on a little bit different trajectory than their male counterparts. So one of the assessments that we can look at, so the deep neck flexor endurance test. We've got superficial and deep muscles, right? So even just as you're sitting there, if you bend your head forward, you've got muscles sort of in the front of your neck that are doing that, okay? This more subtle exercise, where it's more of a forward nod, thinking about an axis coming through your ears, there's also muscles that are much deeper, essentially on the very front of the vertebrae, that are doing that. Those deep neck flexors are what are creating dynamic stability at the cervical spine, okay? So again, working on increasing the strength and endurance of a lot of these muscles is going to be protective, so that now, again, I use that whiplash example, that if you now collide with somebody else, especially, oftentimes they don't know that's going to happen. Right? If I use another example, if you're sitting at a red light and you all of a sudden look up and you see a car coming towards you, what do? We brace and you sort of prepare for it. A lot of these injuries are people focused on the play, focused on the ball coming across the field, and then collide into somebody that they weren't expecting to collide into. So now you have this unanticipated force, and now your neck musculature isn't sort of prepared to sort of try to prevent that. And now as your head moves back and forth, remember your brain is inside of there. So again, these concussions are mild traumatic brain injuries. That's essentially what's happening. So looking at this, can they perform that correctly? Can they get into that position and then elevate their head and hold that position without losing it for a prolonged period of time? Some of the things that you'll see when folks challenge with this is that she's using much more of those superficial muscles, and then again, if they can't maintain that chin tuck. Right, so part of this is laying on their back. They sort of have that little bit of a forward nod, chin tuck, and then hold that, and then elevate the head. Right, so if those deep neck flexors can't do their job, you're going to see them sort of have a difficult time maintaining that position. You're going to see fatigue, or they're just going to sort of drop back down. Okay. Other ways we can think about sort of the neck and upper back as well. So being into this position and sort of elevating the head. So these are now the extensor muscles. So flexion is coming forward, extension is coming backward, so that we can try to target some of those as well. So again, just getting into that position and maintaining the head and neck in a normal position. One of the things you'll often see when people come up here, if that's difficult, is they'll immediately just sort of put their head all the way back. right? We're trying to maintain those standard positions as they now elevate up, hold against gravity, and we can make this more challenging as we sort of increase the duration of time that they're holding. Okay. Now we want to work in each direction. So again, just from the side, now raising the head up. So that's side bending, right? So we thinking about as though we've got 4 sides, right? So flexion is forward, extension is backward, side bend to one side bend to another. So we've got good strength sort of around the entirety of our cervical spine. Again, cervical flexion, sort of working on these muscles that are going to help try to control the position of the head relative to the body when you encounter sort of a challenging event. I mentioned earlier, in addition to neck strength, is thinking about the vestibular system and balance and things like that. So again, some of the things that we've talked about already with regard to balance has a component here. One of the things that will challenge folks with concussion, your vestibular system, which is so our balance, if I take a step back for a minute, our ability to balance has a number of factors. We've got receptors in our muscles and joints that give our brain information for where we are in space. Our vision gives our brain a lot of information as far as what's happening as well, which is why if you have somebody close their eyes, it becomes much harder. Our vestibular system, the inner ear mechanism that helps us understand where we are in space, is another component. So the vestibular system is often what's challenged, with history of concussion. So incorporating some of these balance components is going to play a role there as well. So again, some of these things will be a little bit familiar when we think about how can we challenge balance, right? So this may be a further along progression. Obviously, when somebody's had an injury, we need to think about their full recovery. Have they restored normal range of motion, normal muscle length, normal strength, and all those things. And now, as you start to increase challenge, because many of the things that will set athletes back that have had a concussion is getting back too quickly. So we'll see them as their heart rate elevates, their symptoms will get worse. As they're having challenges with moving their head and neck, now that challenges the vestibular system and their symptoms will get worse. Right? So many folks will have a difficult time just being still and even trying to attend in school and things like that. But then even as they're progressing, as you elevate the level of work and their heart rate is elevating, that can trigger symptoms. Now as they're trying to scan the field or figure out plays and things like that, where they need to be, now that's actually challenging your vision and your vestibular system together, so that can sort of elevate symptoms. So as we incorporate some of these things, whether it's from a prevention standpoint or a progression, again, thinking about incorporating that balance piece. There's key components of that for the benefit in the lower extremities, but then also for our vestibular system as well, which is going to contribute to some of the things specifically related to concussion. Okay. All right. So I wanted to just take a moment here as we sort of wrap up before we open it up to questions. That in addition to me, there's a few other folks that are here that will be around throughout the day to sort of check in with or answer questions if that's helpful for folks. So Jordan and Jeff are here as well, both clinicians within the company. And then also Tom Davis is here, and then Aaron Doherty. So there's a nice contingent from Bay State that's here. And then, folks these are the pamphlets that were left out as far as some of the work that's been done. And again, Bay State and MCR have had a partnership with Matthews Soccer for quite some time as far as, having guidance and having a presence at some of the tournaments and things to sort of target some of these things. So you've got some information there as well. So with that, I want to thank everybody, one, for being here today at a really great venue, and for your attendance here, and then certainly happy to open things up if people have questions at all. Yeah, please.
Thank you, Dr. Nolan, for an excellent presentation. I really like the good exercise, bad exercise video. That's really, really helpful for me. As a high school soccer coach, I've tried to implement this into my training, but it's difficult with 2 matches a week. We really only have 3 days of training. Can you give us some guidance as far as when to start this and when in the training week do you actually use it? I was using it on a Friday. because we practice Mondays and Wednesdays, Tuesdays and Thursdays are matches. So just some guidance of when and how long and all that.
It's a great question. So I would say that what the evidence would say, even though we spent some time talking about, okay, how do we identify who the athletes are that are at elevated risk? I would say that when you look at the literature as far as the success of a program like FIFA 11 or Sports Metrics is another one, ACL Prevent and Burt Mandelbaum's work, that in my bias is that every player on every team should be doing this at the beginning of every practice and every game. And while that sounds crazy to many of the people sitting here, that if you do this, it doesn't take as much time as you think that it would. These things can be incorporated, and you're talking about, on average, I would say 12 to 15 minutes start to finish, right? So I think that in some ways, I would, would love everyone's feedback, but I think part of that is I think what makes it harder is that when it's every now and then, it's brand new to everybody every time you do it, right? Versus if this is in it for all the coaches in the room. So whatever your typical sort of start to practice is or start to the game, that's generally at a certain point, that's not you leading it, right? That's your athletes knowing what to do and how to go about doing it, right? So I think there's a component of incorporating that into this is the expectation, this is what we're doing, this is why we're doing it. And you can do that without taking away, because I think that's some of the biggest challenges. Like, well, we have all these skills that we need to work on, especially at the youth level when they're practicing. We only have practice once or twice a week, whatever it might be. I can't give away more time. That I think you can do these components, and it doesn't, even though we've talked about a lot today, you can have these pieces and they go one right into the next. It's not like, okay, we're going to do this and now there's going to be a 2-minute break. You're going right to the next thing, and it serves as part of a dynamic warm-up, and then you're targeting some of these specific things. Again, I appreciate the time challenge and all those things, but I would say in teams and that I've worked with, is that as you start to incorporate this more and more, it just becomes like it's not even that it's being run by the coaches anymore. The athletes know what to do, and more of it is to your now supervising it and picking out the athletes like, ooh, that doesn't look very good. I need to sort of take a closer look at that. That would be the recommendation, or what I would say the goal is. One, because if like many things, right? So if we all go to the gym or do X activity once a week or every other week, we're probably going to see less of a benefit than if it's consistent. So I think one, to allow it to be efficient, the more regularly that you can do things is helpful, and then you gain the benefit of trying to prevent some of these things as well. So hopefully that's helpful. Yes.
The increase in musculoskeletal injuries following concussion, do we know why that happens?
So I think the short answer is no, not definitively. And I think there's a number of mechanisms there. So I would, in the example that I gave, so if we use ACL as an example, right? We know the risk is higher for female athletes already, okay? We also know the risk for concussion is probably a little bit higher for female athletes. So if you have a female athlete who has a concussion, she may have already had an elevated risk for an ACL injury. And now because of the deficits or the other components related to the concussion recovery, that's probably adding to that a little bit more. I would say when you think about athletes in general and not just soccer, how are we combating the forces and challenges, right? So where people get into trouble is acceleration, deceleration, change of direction, right? So when things are happening quickly in a less predictive manner, our risk of something not going right is higher. So once you've had a concussion, that vestibular and cognitive standpoint of that is likely setting that back even a little bit further, right? So I think there's other pieces as well. I would say that some of that is admittedly from are we getting them back too soon, is like, let's say that you've got many concussions sort of resolve and progress relatively quickly, right? So, generally if people are getting better in a week or so, they probably don't need dedicated sort of vestibular rehab and things like that. Now, if they have prolonged symptoms, that's a little bit different. But even if you take somebody who had a relatively mild injury, recovered fairly well, but maybe they were out of play for a couple of weeks, right? Now they're weaker, they're probably a little bit tighter, their cardiovascular system, right? So even just the time out of participation is likely setting them back, right? Just like any other injury, if you injure one side, the other side is getting weaker, right? Sort of, I didn't talk about it earlier, but one of the biggest things that we see after ACL reconstruction is that there's an elevated risk of another ACL on the other side, right? And that's probably part of the same thing is like, admittedly, you know, people in the rehab standpoint, we're often so focused on the injured leg, like, but they've been limited in their activity, limited in their workout, so their good leg is weaker, right? So I think there's all these things are important. I guess maybe another take home for me is thinking about the entire kinetic chain, the entire athlete, not just where the injury is, and also realizing that any amount of removal from participation, not just competition, but participation, we're going to see a component of decreased cardiovascular endurance, decreased strength, decreased flexibility, things like that. Now, our young athletes will get that back relatively quickly, but if we're getting them back without sort of appreciating those pieces, so I would say if you're getting people back from their concussion, it's not just their vestibular testing and impact testing and things like that, but looking at their strength, looking at some of the other musculoskeletal things that we talked about. It's a great question. Yes, sir.
I'll just speak loud. What's your experience with diet and menstrual cycle with female athletes and injury prevention, recovery, the whole nine yards?
Yeah, so I'll take the easy part of that first, diet. Obviously, diet plays a huge role. You know, I mean, I think, and there's other presentations today. So sleep plays a big role. Diet, what we're putting into our body. So, and I'm not a nutrition person by any stretch, but you know, I think some of that is in order to have the fuel to do what we're asking the athletes to do, they need to have reasonable diet, and that's probably even more important from a recovery standpoint. Our body's healing response relies on that. So certainly outside of my expertise, and that's something for me that I'll often refer athletes to, you know, a nutrition specialist or a dietitian or things like that, both from a recovery and then just sort of having baseline things. Obviously, often a little bit more challenging sometimes with our female athletes. If you do have any red S or female athlete triad or, you know, eating disorder concerns or things like that. Again, not to say that that's exclusive to female athletes because we see that in males as well. Now, menstrual cycle, I've practiced for more than 25 years, and there was a lot of research along the way looking at the impact of menstrual cycle and hormones on ACL risk. Times where there's increased relaxin likely puts the ligamentous structures at a higher risk. Now, and while I'm not debating that, the utility of that in the real world is limited, right? Because the reality of us having every female athlete on oral contraception to try to control that is not reasonable, right? The other component of that is that you're also probably not going to sit out an athlete because of where she may be in her menstrual cycle, right? So even though that there are times where their risk is higher because of the hormones and the impact on the ligamentous structure, you know, what we focus on from a prevention and a rehab standpoint are the modifiable risk factors. Right? I can't change I can't change their sex, I can't change their menstrual cycle. We focus on what we can change, and that's a big component of the neuromuscular control. We can get people stronger, we can improve their balance, we can make them more flexible as well. And those neuromuscular components is where the vast majority of the evidence in the literature is sort of focused. Again, there's absolutely components with our female athletes that elevate their risk that, you know, we're probably not going to see that pendulum swing that it's ever even with their male counterparts, right? Because there's components of their anatomy from skeletal anatomy and muscle anatomy, and then in addition to the menstrual cycle. So I think that it's important to understand those things. And I would say that when families or athletes or coaches ask me questions along those lines, it's like, that's our reason to make the other stuff we can modify as good as we can. Right? So there's pieces that we can't change. That means you probably need to be that much stronger, right? That means you probably need to have that much better balance than somebody else. So hopefully that helps. Yes? Oh, no. Sorry. Yes.
Do you think it's beneficial at all to do any of these exercises barefoot when possible?
Yeah. So I think that the benefit of not having shoes is that you're getting greater demand on, specifically on the intrinsic muscles of the foot. So, you know, shoes, protect us from the ground and that sort of thing, but they also limit some of the input that we might get. So I will say that in a clinical practice, like when I'm having patients do balance activity, that's typically shoes off. They may have socks on or that sort of thing. Again, if that's feasible, then sure, how much you want to have people taking cleats off and on the pitch. Yep. Yeah, definitely. I do. And I think for me, admittedly in my own practice, I see a lot of foot and ankle pathology. I work with a lot of runners as well. So shoes off allows me to sort of hone in on what is their foot doing, which can be helpful as well. So I do think that there's a benefit of challenging that. In my view, we talked about doing it on the ground versus on an unstable surface. Doing something in shoes is probably easier than out of shoes, right? So it's another way that you can probably add it, make it a little bit more challenging as well. Yeah, great question. Any final things? Yep, in the back.
My second question kind of goes hand in hand with that. Any observation on shoe type or playing surface type and how those correlate to injuries?
Like Achilles tendon ruptures in the NFL? Yeah. So I will say, yes, there is. I would say soccer is the shoe interface there's a little bit less variability because, what athletes need to wear, whether indoor or outdoor, is sort of what they need to wear. As far as injuries and things that we've seen, is often related to the coefficient of friction. So the interface of the shoe with the surface. So, it's not soccer admittedly, but if we think about what we've seen this year, if people follow the NFL and Achilles tendon ruptures, or we see with ACL injuries, is if you're in a cleat that grabs the surface really well, in other words, you land when you're cutting or changing direction or accelerating, and it doesn't move at all, that force translates up the kinetic chain to the knee or to the ankle, etc. Which is why I think the field turf and the things that are available now versus when 10 or 15 years ago is very different. But you've seen a lot of transitions back to grass and things like that. While it can be more challenging to maintain, is you don't have that same sort of really challenging coefficient of friction. I will say that's a component that has played a role in cleat design. That in athletes that are changing direction, you will often see more rounded cleats versus squared off cleats. People that are just going front to back, like linemen or baseball players that are not sort of having to move around people, you'll often see squared off cleats. But if you have to change direction, part of that is the 90-degree angle cleat is not allowing for any sort of shift or subtle movement of the cleat with the playing surface. So again, the force is happening. Right? So whether you get a little bit of shift in the shoe or the cleat with the surface, or it goes to the ankle or the Achilles or the knee and possibly the ACL. I do think there's a component that we're seeing probably some subtle shifts in playing surface and then in shoe wear as well. And I think that's probably going to not happen as quickly in our younger level, right? I mean, obviously, professional teams have the financial resources to do things like that quickly, but at your typical towns and things like that, that's probably not feasible to happen instantaneously. So I do think being thoughtful about, how much change of direction does somebody need to have and what sort of style cleat should they have. And then also, again, I think that there's